quite a bit of territory to cover. We're going to finish the business that I started Tuesday, and so we're going to finish this rheumatic diseases, and we're going to run through a whole bunch of stuff, including the autoimmune diseases, some infections in the joints, and some vasculitis. We're going to start with systemic lupus erythematosis. This is a fairly common disease. 90% of the patients who present with this illness will be women. No one knows exactly why that is. It has many genes that lead to its inheritance, and a lot of people think that this is an autoimmune response to an infection, but the exact organism has not been found. So one of the ways to think about this disease is the many organs that it affects. It causes problems with the skin. There's a malar rash, and it's this rash across both cheeks that occurs in acute lupus, and it's where the disease gets its name, because lupus means wolf, and it's a butterfly rash. Acute lupus usually presents with this rash. Not all people with lupus have this rash. Subacute lupus has a polycyclic rash that comes and goes, has hyperpigmented circles. Chronic lupus has papules, plaques on sun-exposed surfaces. So one of the things that happens when people present initially with lupus is I get this rash only where I am exposed to the sun. That's pretty common. Painless ulcers, painless oral ulcers, alopecia, Raynaud's phenomenon. Now you're going to see Raynaud's phenomenon. You all know what that is. It's a white and then red and then blue sort of turn of your fingers. And Raynaud's phenomenon is common out there. It's mostly not related to diseases, but it's really common in these autoimmune illnesses, probably because there's hypersensitivity of vascular endothelium. Musculoskeletal involvement. So most people who present with lupus present with joint disease, and it's by and large symmetrical. It's bilateral, although it can occur in a single joint, and it can be large joints or peripheral. And myalgia, just aching muscles, is present at up to 85%. So many doctors just really hate it when someone comes in and says, well, I just don't feel very well, I've lost all my energy, my muscles are aching, my joints are kind of stiff. Oh my goodness, I mean the differential now is huge, right? All the way from depression to my husband or my wife just left me to all these inflammatory diseases. So it's a common symptom. The kidney is commonly involved. The thing I want you to remember about kidney involvement in lupus is it's associated with the double-stranded DNA and the anti-Smith antibody. These antibodies do not have a very high sensitivity or specificity. The likelihood ratio turns out to be anywhere from 1.5 to 2.5, so it's not a powerful test. But anti-double-stranded DNA and the anti-Smith antibodies are related to, commonly found in people who have lupus and kidney disease, and they're not found in other anti-inflammatory diseases, other autoimmune diseases. Okay, so just like with ankylosing spondylitis, you want to remember HLA-B27. With lupus, you want to remember anti-double-stranded DNA and anti-Smith antibodies. So what happens is if the patient comes in with lupus, they come in with all this joint stuff and fatigue and muscle weakness and muscle pain and so forth, and you work them up and you decide to have lupus. And you look at their serum creatinine B and they're elevated, they got protein in their urine, they got cells in their urine. You got to send them to a nephrologist because they need a renal biopsy. there are so many ways that lupus can affect the kidney that they have to have a renal biopsy to figure out how to treat them. Okay? So the fact that a person with lupus has renal disease means they need to go see the nephrologist. Neuropsychiatric involvement is common. This is most likely, most of the time, a vasculitis in the brain. It's really common. It's really hard to diagnose. If it's the only presentation, they don't present with arthritis or myalgia or a discoid lupus, then it's a really difficult diagnosis. And what you have to be very careful about is not writing them off with a psychiatric diagnosis. Okay? So when you're thinking about differential diagnosis, we've said this before and I can't say it enough times. When you're thinking about a differential diagnosis, always think about categories. Don't think about names of diseases. Think about categories of illness. And one of the categories that always ought to be in your differential is autoimmune disease, congenital, acquired, autoimmune, cancerous, infectious. These categories will keep you from missing the boat, okay? 19 possible neurologic manifestations. I'm not going to list them. Aseptic meningitis, headache, anxiety disorder. These people can present exactly as if they have a psychiatric illness. So you have to be careful. They can present with peripheral nerve disease, mononeuritis multiplex. Okay, we're going to talk about mononeuritis multiplex 2 or 3 times today. I want you to remember what this is. Mononeuritis multiplex is a peripheral neuropathy that presents with numbness. Mononeuritis multiplex generally comes and goes. It's caused by small vessel inflammation of peripheral nerves. And these vessels get clogged up from whatever the autoimmune response is, and then they reopen. They clog up, they get numb, they reopen. Mononeuritis multiplex. You will most likely never have a patient tell you, I'm having numbness that comes and goes. The way you pick it up is you have it on your review of systems. If you're doing a complete review of systems on a new patient and you ask them, do you have numbness? You go, well, I sort of do, but it goes away. Well, tell me about that. Well, I get numbness on my hand and it goes away. Then sometimes I'll get it on my face and it goes away. That's mononeuritis multiplex. They don't generally offer that without being asked because it goes away and they think it's probably nothing. They can get autonomic lesions, cranial nerve lesions, and they can have polyneuropathy. So this is SLE is a disease that has a predilection for the nervous system. Cardiovascular exam, cardiovascular involvement can be anything from pericarditis, which you diagnose if they have active pericarditis, they have chest pain, and they have a friction rub most of the time. And you have to worry about them filling up with so much fluid that they tamponade. But they can also get cardiac valve thickening. Liebman-Sachs endocarditis, misspelled, but Liebman-Sachs endocarditis is what's called when lupus affects the heart valves. You can even get vegetations on the valves, which you see by echo, but it's not infectious. Pulmonary, okay, what I think I said last Tuesday, and I'm going to say it again today. If you have an autoimmune disease that affects the lungs, it's most commonly going to cause interstitial lung disease, okay? But it can also cause pleurisy, and pleurisy presents with the pain saying, I have chest pain, it gets worse when I take a deep breath, or when I cough. Now, SLE is known to be a disease that causes a decrease in all the cell lines on the CBC. So you can have anemia, you can have neutropenia, you can have leukopenia, you can have thrombocytopenia. So all three cell lines can be reduced. Or you might have a patient that comes in with lupus and only has one of them reduced. But when you have cytopenia in a patient who's presenting with joint pain, think lupus. There's also a hemolytic anemia, a warm antibody, spherocytic hemolytic anemia. Have you studied anemias yet? So what happens with lupus when it presents with a hemolytic anemia is that the antibodies are warm and they attach to the cell membrane of the red cell. And when they try to get through the sinusoids of the spleen doesn't completely destroy the cell, but takes pieces of the membrane off. And the cell folds back together. And they quit being those biconcave discs and they start looking under the microscope like spherocytes. So lupus, hemolytic anemia due to lupus is one of the few things that cause spherocytic hemolytic anemia. Antiphospholipid syndrome and lupus anticoagulant is something that'll be on tests. Okay, so antiphospholipid antibody and lupus anticoagulant are the same thing. Those are the same molecule. Okay, and they're an antibody that leads to increased clotting. So when someone comes in with a deep vein thrombosis or some sort of a clot that you don't know where it came from, one of the tests you always order is antiphospholipid antibody / lupus anticoagulant. They can have it without having lupus. But if they have lupus and present with a blood clot, that's probably what's going on. These are antibodies to endothelium, monocytes, platelets, and it makes the vessels prone to clotting. Gastrointestinal involvement can involve the esophagus, sterile peritonitis, mesenteric vasculitis, mesenteric vasculitis can be easily confused with acute appendicitis. So you have to be really careful when some young person presents to the ER with abdominal pain. If the only organ being affected is their mesenteric vessels, you can make the error of making the diagnosis of appendicitis. Now that we have CT scans, you probably won't make that diagnosis. But when I was training, we didn't have CT scans, and so we had to be really careful. Now you don't have to be so careful, you just order CTs. Malignancy is 7 times more common in people with lupus, specifically non-Hodgkin's lymphoma, no one knows why. So here are all the antibodies that are associated with lupus. And they're not these are the percentages of people who have lupus who have this antibody. So they're not very good for diagnostic purposes. The 2 antibodies I want you to remember with lupus are anti-double-stranded DNA antibodies and anti-Smith antibodies. So the ANA has to be interpreted in light of the clinical history, in light of the pre-test probability and post-test probability, okay? Now, when you're trying to figure out if someone who's presenting to you think might have lupus, and you're thinking, is this an inflammatory disease? So you're trying to figure out, do I order a erythrocyte sedimentation rate, ESR, or do I order a CRP? people, I don't know why this is, but practitioners have sort of a preference. I'm kind of an ESR guy. So I always order a Cedrate instead of a CRP. I don't remember CRP. In lupus, ESR is preferred over CRP because when the patient has an acute flare-up of lupus, it's common for the CRP to be negative for some reason. So if you're thinking lupus, use the Cedrate. Okay. Big time notice, C3 and C4. You all know about complement fixation, what's going on in the complement system. C3 and C4 are the two molecules that you order when you're worried about lupus, because in lupus you can get an immune complex syndrome or an immune complex disease. And so when you're working them up, C3 and C4 are ordered because they're decreased in the immune complex disorder. And Dr. Latassi tomorrow morning will talk about the treatment of SLE. I don't want to spend your time. Sjogren Syndrome. So this is an immune-mediated disease of unknown cause. We don't have any clue what causes this, but it causes an infiltrative inflammation of the lacrimal ducts of the eye and the salivary glands of the mouth, and it presents with dry eyes and dry mouth. And there are, when you do biopsies, there are CD4 cells, not CE4 cells. There aren't any such thing. But these are CD4 cells in the biopsy material. And it's pretty rare, 1.5% prevalence. We don't know what causes it. People present with dry eyes and dry mouth. Okay. Now, when you're working them up, there's a Schirmer test, S-H-I-R-M-E-R, Schirmer test. There are these little strips that you put under the eye, under the bottom eyelid, and when you put something under the bottom eyelid, the eye will tear up, right? And so you just leave it there for 60 seconds and then measure what percentage got wet, and that tells you what kind of a test you have. Dry mouth is a historical diagnosis. The best markers for Sjogren syndrome are anti-Rho SSA, anti-Law SSB. These are bizarre names. These enzymes are bizarre names. I'm going to tell you right quickly why these are named this way. Rho and Law were discovered at the University of Connecticut by a friend of mine back in about, I don't know, in the late 60s or early 70s. Mo Reichman found these, and he found them in patients whose names started with R-O, like Roland, and L-A, like Lara. And these antibodies were brand new. No one had ever found them before. And he found them in people with Sjogren syndrome, and he called them anti-Rho and anti-Law for the patients he had these symptoms. 10 years later, someone else discovered the same, well, that wasn't 10 years. Probably was within the year. Someone else in some other university found the same antibody, but didn't know that Morris had already found them and named them. So they named them SSA and SSB. And for whatever reason, both names have stuck. But they're the same thing. And both names are stuck on the antibodies because different people discovered them. So, Rho and Law, SSA, SSB, associated with Sjogren syndrome. If you're trying to work up there are a lot of people with dry eyes, there are a lot of people with dry mouth who don't have Sjogren syndrome. So you have to be careful about making this diagnosis. If you think you have to know the diagnosis, and you don't have positive antibodies, you may have to do a lip biopsy. Not you, or not me. People scream when I get a hold of a knife. But, you send them to someone with a knife who knows how to use it and do a biopsy. The treatment for Sjogren syndrome is symptomatic and local. You don't use big time steroids or anything. use eye drops and try to keep their mouth wet. Mixed connective tissue disease. Mixed connective tissue disease is named appropriately because it's a mixture of 3 illnesses: SLE, systemic sclerosis, polymyositis. They don't have full-blown anything, but they've got this overlap syndrome, and they commonly present with hand swelling and synovitis, just like people with SLE do. They present with esophageal reflux, and they have esophageal reflux because they have symptoms, or they have a pathophysiology of systemic sclerosis. We'll cover systemic sclerosis at the end of this talk, but it's an autoimmune illness in which fibroblasts lay down fibrin in tissues and in places where they shouldn't be. So your hands get stiff, your esophagus gets stiff, your face gets stiff. People with systemic sclerosis can't open their mouth very wide, they can't smile very well when it's in their face. The reason they present with esophageal reflux is they get this fibrin and these fibers in their esophagus. Interstitial lung disease, there it is again. Pulmonary hypertension because of the interstitial lung disease. You may have to use high-resolution CT to figure out what the lung disease is. Now, the thing to remember about mixed connective tissue disease is that it's the anti-U1RNP. That's the antibody that goes with MCT, mixed connective tissue disease. I'm trying to point out which of these antibodies go with which disease so you can memorize them, because if they're on an exam, this is the way they'll show up. These things are such low sensitivity and specificity that you've got to kind of match them up to figure out when to be ordering them. The other thing to know about MCTD is that if you just get an ANA, if what you just order is an ANA, they come back sometimes with some sort of pattern. And speckled pattern goes with mixed connective tissue disease. That could show up on an exam. I could see that coming up on a PANCE exam. Speckled pattern ANA goes with mixed connective tissue disease, and then there's the anti-U1RNP again. Management is individually. This can be really minor, or it can be full-blown where you have to use glucocorticoid, steroids, azathioprine, methotrexate, DMARDs kinds of drugs. Most of the time, if it's bad enough that they need drugs to calm it down, they need to be sent to a rheumatologist. Okay? Crystallopathies. Okay, so we're going to talk about joint pain, joint swelling, joint inflammation caused by crystals. Gout and pseudogout. You're going to get a lot of gout by Latassi tomorrow. I'm going to try to cover the pathophysiology. She'll cover most of the treatment. So this is a disease that is characterized by recurrent acute episodes. And the episodes are because crystals form in the joint space. And when crystals form in the joint space, they attract inflammatory cells. Okay? So your typical gout patient is older than you. Old men, those are anyone older than you, right? Old people, 50s, 60s, 70s, 80s, who come in and say, whoa, I woke up at 2 o'clock in the morning and my right big toe, that first joint in my right big toe was on fire. It was absolutely on fire. I went to bed normal. I woke up at 2 or 3 in the morning, on fire big toe, and he's got a big toe joint, that big around, red, and you can't touch it. He wouldn't even let the sheets touch it. Okay, so what happens is uric acid, the serum uric acid's too high. The serum uric acid gets into his joint, and when the temperature falls to a certain level, they crystallize. These molecules of uric acid crystallize, and when they crystallize, they recruit inflammatory cells. The reason it happens in the big toe is it's the coolest part of the body. Isn't that cool? And these are temperature-dependent crystallizations. Now, you can it's not a game you need to play, but big toe is the most common place for this to occur, especially in the first attack. Second most common is the ankle. Third most common is the knee. You know, then the metacarpal, then the wrist, and then the elbow, because they're all getting warmer as they get up the extremity and close to the central body. It's all temperature related. So what happens is we all have a uric acid level. Okay, some of us have high uric acid levels and never get gout. We don't know what that's about. But if your uric acid level is high, then you're more likely to get gout. Okay? If you look at purine metabolism, the end product is uric acid. And in humans, we don't have uricase, which is an enzyme that breaks uric acid down. So uric acid is an end product of purine metabolism, and the rate-limiting enzyme for that is xanthine oxidase. Xanthine oxidase is to gout as HLA-B27 is to ankylosing spondylitis. It'll be on the exam. And they may put it in there in a jillion different ways. But you've got to know that xanthine oxidase is the rate-limiting enzyme in the purine metabolism leading to gout. It's also the enzyme that we attack with one of the drugs. And you'll hear Latassi talk about that over and over. Saturation concentration of urate is 6.8 milligrams per deciliter. What is a deciliter? What? A tenth? Not 1,000, not a tenth. 100. It's 100 liters. Okay. So milligrams per deciliter. Okay. So if the concentration of uric acid in the joint is above 6.8 and the temperature falls appropriately, you're very likely to crystallize those uric acid, make crystals in your joint space. We define hyperuricemia based on this information. And so if the patient's uric acid in their blood is above 6.8, we call it hyperuricemia. And we treat gout over long periods of time to try to drive the uric acid down below 6.5. And it's all based on the fact that the concentration, or the saturation concentration, it occurs at 6.8. Okay? So that's a number to remember. You're trying to treat these high uric acid levels with a drug called allopurinol down below 6.5 so that this doesn't happen. Okay? Now, patient comes in, if it's in any other joint besides the big toe. If the patient comes in with the big toe that's this big, they probably have gout. Now you may very well still need to stick a needle in it, or have someone stick a needle in it and look at it under the microscope, because other things can do this. Pseudo-gout can do it, and infection can do it, and trauma can do it. You should be able to figure out if trauma did it by taking a history, but you can't tell if they have gout versus pseudo-gout. You can't tell if they have gout versus an infection without putting a needle in it, okay? So you have to do, you put a needle in it, you get some of that fluid out of the joint space. You do crystal analysis, you send it off to the lab, and they will look at it under the microscope. And they do polarized microscopy to see if it's negatively birefringent. I've got that in big bold letters because that's something they might like on the pants exam. Negatively birefringent crystals under the microscope is gout. I don't know what negative birefringence is. I don't need to know what it is. Actually, it means that they're yellow when the crystals are parallel to the polarizer, and they're blue when they're perpendicular to the polarizer. But since you're not going to be using the microscope, the pathologist is going to be doing this. You just need to know that these are negatively birefringent crystals, and they're long. They look like a spear. If they're pseudo-gout, they're positively birefringent, and they look like a box. Okay, so these people look like they're infected. I mean, look like they're inflamed. They have high ESR, high CRP. The differential diagnosis, as I said earlier, trauma, pseudo-gout, and infection. Okay, so there are three presentations of gout. One is acute. That's the one I just described. That's podagra, where you wind up at night with a big red toe. Intercritical is that big toe has now calmed down. You're on some daily medication and so forth. And there's a period between acute attacks, and that's called the intercritical period. And then there are people who have chronic gout, where they have deposition of uric acid crystals at various places in their body a lot. Okay? The acute management, the management of an acute attack, it'll be interesting to see if Latacet gives you the same byline here, but what I use is 0.6 milligrams of colchicine every hour until the pain goes away. I think this is different. We used to use 1 milligram of colchicine every hour until they throw up. Yeah, when I was a resident, that's how we did it. Put them in the hospital, give them 1 milligram of colchicine every hour until they threw up. And someone figured out that wasn't very nice and started doing some research, and this is what they came up with. Okay, now you want to inhibit the xanthine oxidase because that's how you keep them from, that's how you lower the serum uric acid, right? Does it make sense? Xanthine oxidase is the rate-limiting enzyme. If you limit it, you'll reduce the amount of uric acid you make. But you don't want to start the xanthine oxidase inhibitor when they come in. And when they come in, they may have a normal uric acid level. So gout is not, acute gout is not diagnosed by a high uric acid level. It's diagnosed by putting a needle in the joint space and looking at it under the microscope. I've not ever been completely clear on why this is. I've worried about it. I think my hair fell out worried about that. But I never did figure out the answer really. You don't start a xanthine oxidase inhibitor like allopurinol, or if you use a stat, during the acute phase because you'll worsen the acute phase. I don't know why. But you wait to start the xanthine oxidase inhibitor a day or 2 or 3 later, after you've got them cooled off, then you start them on the xanthine oxidase inhibitor to reduce their uric acid and hopefully prevent it. Get it below 6.5, okay? And they should be on it for life. Common reasons for treatment failure. I don't know how many people I've seen who come in with acute gouty attack and they're on allopurinol. What in the world? Well, here's the reason. They were put on allopurinol, but no one followed up their uric acid levels. They didn't treat them to target. The target is 6.5 or lower. And they weren't using a high enough dose. For some reason, many doctors think that 300 milligrams a day is the highest dose you can give of allopurinol. Turns out you give 800. The FDA has approved 800 milligrams. So if you've got them on 300 milligrams and they're not at target, you just keep increasing the dose. Okay? If they can't take allopurinol, then you give them an expensive drug if you've used a statin. Here's chronic gout, and these lumps on their fingers are tophi. These are gouty tophi. If you were to slice those open and look at them, they kind of look like cheese, but they're uric acid crystals that are constantly always in their fingers. Gouty tophi. Bizarre. Okay, here is pseudo-gout, calcium pyrophosphate. So there's a lot of confusion about this disease in terms of terminology. Chondrocalcinosis, which is pseudo-gout. Chronic CCP crystal inflammatory arthritis is another way to name it. And osteoarthritis with CPPD. CPPD is probably the new most appropriate. Calcium pyrophosphate deposition disease. As I said earlier, calcium pyrophosphate, when you look at it under the microscope, is a rectangle. Looks like a box. Looks like a little rectangular box. The mechanism is not quite worked out. But a young person who presents with CPPD, one should worry about other diseases. Now, old people commonly get chronic with CPPD. It's really common. But if a young person comes in and they have chondrocalcinosis, which I'm getting ready to show you a picture of, then you've got to worry about other diseases: hyperparathyroidism, hemochromatosis, hypomagnesemia, hypothyroidism. The one you really have to worry about, and the one that will creep up in your practice, and the one that will creep up on PANCE exam, is hemochromatosis. Okay? So a young person who presents with CPPD, you're going to wonder, why in the world did they do that? And you ought to worry about hemochromatosis. Hemochromatosis you've studied already? Mm-hmm. It's an iron storage disease. It's genetically predisposed. And people inappropriately store iron in their tissues. People with hemochromatosis who don't get diagnosed and don't get treated die of heart failure. They die of heart muscle failing because it's got too much iron in it. People with hemochromatosis who get treated, mostly by phlebotomy, keeping their serum iron down so that you can leach it out of these tissues, might just die of old age, but they might die of liver cancer. We used to say, well, hemochromatosis is bad. If you don't treat it, they die of heart failure. If you treat it, they die of liver cancer. Well, that's not necessarily true, but if you can keep them alive long enough by preventing their heart failure, you might keep them alive long enough to get liver cancer. Okay, so calcium deposits in cartilage is what CPPD does, and there are linear densities parallel to the surface of the cartilage. This is, what is this, a sunset or a sunrise view? Yeah. Yeah? This is a sunrise view of the knee. So the patient's laying down with the knee up like that, and they're taking the x-ray like this. So you've got the patella on top and the femur on the bottom, and what you're seeing is this linear deposition of calcium in that joint space. Everybody appreciate that? chondrocalcinosis. It's seen on a sunrise view of the knee, and it's due to CPPD. So, if it occurs acutely, you need to put a needle in the joint space because you can't tell it from gout. And you treat them so differently, right? You treat them so differently. The management of pseudogout is symptomatic. You just decrease the inflammation with an NSAID or something and wait a while and it'll get better. Gout has to be treated specifically usually with colchicine, some very powerful anti-inflammatory. Okay, let's talk just briefly about infectious arthritis. Have you already taken the infectious arthritis lecture off the schedule? Okay. So we had a schedule for this for a whole hour, but I'm going to try to cover it in a little less than time than that. Quite a bit less time than that. So infectious arthritis is really an arthritis where the joint space has been invaded by a bacteria or a fungus or a virus or is reactive to a viral infection. Okay? Now, generally, you can figure out what happened. Generally, you can see a break in the skin close to the joint, or you can uncover something in the history. If they're an IV drug abuser, that's not too uncommon. They get bacteria in their blood and then it finds a joint. Why it finds one joint versus another, no one knows. But or they get infected when you are needling a joint. If you don't do that right and you put bacteria in there, they wind up with an infection. Cellulitis of the skin can do it by contiguous spread. Septic bursitis, if there's a bursa just outside that joint and it gets infected, you can get an infected joint. Okay, so infected joints are basically an emergency, right? An infected joint has to be dealt with. It has to be dealt with, and it almost always needs to be dealt with by an orthopedic surgeon. Okay? You might take the time to make the diagnosis by sticking a needle in it, but my personal preference as a general internist was when I saw a joint that I felt was an infected joint, I called the orthopedic surgeon right then. I wanted them involved from the outset. They stuck the needle in, they ordered the test. Okay, so you got to do a gram stain to see if this is a bacteria. You got to do a fungal stain. You got to do cultures and acid-fast stains for tuberculosis. Tuberculous joint disease is pretty uncommon these days because we've done such a good job of getting TB out of the population. But TB is a real problem in patients who have drug addiction or who have chronic illness or who are immunosuppressed or who have AIDS. Okay, so you have to worry about TB if they're immunosuppressed. And then there's gonococcus. Okay, if you suspect at all that this is disseminated gonococcemia, you need to not only put a needle in the joint, but you need to do a gram stain of pharynx, urethra, cervix, and anus. Try to figure out where this bacteria came from, okay? This is a long list, but this is just a common sense list. You're at higher risk of getting an infected joint if you're immune compromised. And this list is just the list that you've heard over and over and over about people who are immune compromised. Old people, alcoholism, cutaneous lesion, diabetes mellitus, end-stage renal disease, history of steroids. I mean, it's all the same list, right? Okay, so what organisms are we most likely to see? We're most likely to see Staph aureus. Staph aureus lives on the skin. That's where most of this stuff comes from. And so Staph aureus is the most common organism to cause an infected joint. Strep pneumo is the most common organism to cause pneumonia. It commonly, when it causes pneumonia, causes a septic situation, so you have bacteria in the blood. If you've got bacteria in the blood, then they can attack a joint. So strep pneumo is probably another common invader. The gram-negatives would be non-gonococcal gram-negative organisms, and they would run the whole gamut. You would probably figure out what the most likely organism is if they had some other disease, right? If they had something like Crohn's disease, or they had something like ulcerative colitis, or they had recent bowel surgery or something. Disseminated gonococcal infection is gonorrhea that has now disseminated into the vascular tree and causes systemic ulcers. This is almost exclusively seen in women. Why is that? It's almost never seen in men. Open system. Open system. Partly true. What happens when a male gets gonococcemia? He gets dysuria. It affects the distal urethra, and when they pee, it burns. And they know that that's a red flag, and they get in to see somebody. They come in and say, I'm burning when I pee. So a male who gets gonococcus infection generally shows up at the medical provider quickly. You just do a smear, gram stain it, look under the microscope, and you've got a diagnosis. Okay? Treat them with IM antibiotics, and they're cured. What happens in the woman is it's usually deposited in the vagina. It then migrates up through the cervix into the uterus and winds up out in the fallopian tubes, or one or the other. It just kind of keeps going in that system. And it winds up in the fallopian tube and causes an abscess. Okay? And so the woman doesn't have dysuria. She doesn't have an early warning red flag sign. It just sits there for a while and works its way around the female urogenital system, and now it's got time to set up shop, create an abscess, and disseminate into the blood. So disseminated gonococcemia is almost always a female disease. I've only seen it once in a male. Now, when they get disseminated gonococcemia, part of this is due to part of the presentation is due to the bacteria itself, part of it is due to the immunologic reaction to the bacteria, that they present with acute arthritis, fever, skin lesions. These are vesiculopustular lesions, hemorrhagic macules, and they are distinctive. It's hard to describe what they are, but these people are febrile, they look sick. These are macular, and they've got little pustules and vesicles on them. And you want to put gloves on to examine these, okay? They're not as infectious as secondary syphilis, but you want gloves on if you're going to be pushing around on these things. Disseminated gonococcemia. This is a distinctive skin lesion. Fungal infections. These are a list of 5 fungi that can cause joint disease. Generally, what happens is they've got a fungal infection somewhere else. They've got coccidioidiomycosis of the lung, or they've got cryptococcal meningitis, or they've got Candida albicans sepsis. They've got the fungus. Generally, you already know they've got the fungus, and so they get a hot joint, stick a needle in it, and there it is in the joint space. I think for your benefit, what you ought to do is memorize these 5 fungi that are found in joints. Now, viral illnesses are kind of interesting. There are hepatitis B and hepatitis C commonly present with an arthritis in that initial prodromal stage. Have you studied hepatitis B? Mm-hmm. So you've studied the fact that you get the infection, you get the virus, there's a prodromal stage, then there's a latent stage, then there's a chronic stage. It's a weird sort of infectious disease, and you kind of have to know how each stage presents to figure out how to suspect it. Hepatitis B is getting less and less common because we're immunizing against it now. Most people can't get into college without a hepatitis B vaccine. Is that true for you guys? When you went to college? Huh?
I have no clue.
No clue. I think most, well, I don't know.
They're vaccinated as babies now.
What's that?
They're vaccinated as babies now.
Oh, they are.
I've heard. Yeah.
For babies, they're getting vaccinated.
Yeah, since I was a baby. I don't know when they started it. I think like mid-90s, 95. Yeah, I was thinking mid-90s when they started vaccinating all children.
Yeah, so it's a little less common. Hepatitis C also. Now these generally don't have the virus in the joint. These are usually an inflammatory arthritis that is immune driven. There's an immune response to the virus, and the antigen antibody complex affects the joints and makes them inflammatory, and they go away. They go away without treatment. Okay. Now, parvovirus B19, you're going to probably cover again when you do pediatrics. But it's one that people like on exams as well. Okay, so this is called fifth disease. You know why it's called fifth disease? I don't know this. I don't know either. It's a weird name, fifth disease. It's parvovirus B19.
They had it wrong on 1, 2, 3, and 4.
Maybe.
Maybe
Yeah.
they figured it out.
Yeah. Might have. A DNA virus, it's parvovirus. The other name for it is Erythematosis. Harder to remember than fifth disease. They present with an acute arthritis. They're usually young, usually pediatric patients actually. It resembles acute rheumatoid arthritis, but they don't have any of the markers of rheumatoid arthritis. They don't have rheumatoid factor. They don't have the CCP antibody. Right? For rheumatoid, you need to remember rheumatoid factor and CCP antibody. Those are the two antibodies that go with rheumatoid disease. Fifth disease don't have those. They have fever, and then what's always on the exam is a slapped cheek. A slapped cheek erythematous rash. It looks as if someone slapped them. You want me to show you what that looks like? Like someone slapped them up against the cheek, and so they got these erythematous rosy cheeks with a fever. And the important thing is it goes away on its own. You just treat them with supportive care, and it'll get well on its own. You don't have to treat them with anything. I don't know how this is pronounced. You know, chikungunya?
Chikungunya.
So this is an Asian African virus. Chikungunya. Asian African virus. It's not native to the United States, but we see it in the United States because of travel. Okay? These people, it's not on this slide, this is bizarre. It's not on this slide, but they present with acute arthritis, the thrombocytopenia, myalgia, fever, and leukopenia. So they could look like they had lupus. They could look like they had acute rheumatoid arthritis. But they have an IgM antibody to this virus. IgM being the acute phase antibody, it's an IgM antibody. And you would most likely pick this up if they'd been traveling to Africa or Asia. Okay, that's the infections. infection is one of those categories I was talking about earlier, right? Congenital, autoimmune, infectious, malignant. These are the categories. And you got, when someone comes in with a big red hot joint, you got to wonder, is that infected? Is that an antibody response? Is that a response to a systemic virus? What's going on? Okay, so idiopathic inflammatory myopathies. These are muscle diseases. IIMs. They're autoimmune, they're inflammatory, they involve muscle fibers, so they're called myositis, and they result in weakness and pain. So people just say, I just have weakness and pain all over. There are three of them: polymyositis, dermatomyositis, inclusion body myositis. They all present pretty much the same way, except that dermatomyositis has a lot of cutaneous findings, which I'm going to show you pictures of. But what I want you to remember is that polymyositis is a CD8 positive T cell response. And you'll find those cells not only in the blood but in the muscle tissue. Dermatomyositis is an immune complex disease, and inclusion body myositis is a myodegenerative disease, and on biopsy there are vacuoles in the muscle cells. That's how you differentiate these pretty much. So these are really rare diseases. I thought I had one time when I was about 50. I was riding my bike about 100 miles a week, and I was out riding my bike, and my legs went south. Have I told you this story? My legs went south. I mean, south at about 20 miles. My legs were gone so badly. I was in really good shape. I was running 20 or 30 miles a week and cycling all the time. I was in great shape, and they were so bad I had to have someone, not pull me literally, but I had to follow behind someone to get the last 10 miles in to eat breakfast. And it happened on a Saturday morning, and it never happened to me before. I was about 50 years old. Sunday morning I went back and got on the same bike ride, and at 20 miles, boom, I was done again. So I called my internist, who had been a resident of mine. And she got me right in, and I went in and I said, Susan, I think I've got polymyositis. She looked at me and said, what? I don't think so. Well, if I don't have polymyositis, I have dermatomyositis. She said, oh, why don't you let me take the history? I said, well, that's what I got. She said, well, have you ever seen polymyositis? No. Have you ever seen a patient with dermatomyositis? No. Well, I haven't either, so if you haven't, you're the first one either one of us have seen. Why don't you let me take a history? And so she started taking a history, and one of her questions was, you have nocturia? I said, yeah. There's 50. She said, how many times you get up to pee at night? I said, 3. She said, you get up 3 times a night to pee? I said, yeah. She said, well, maybe you have diabetes. I said, I don't have diabetes. I don't have any excess body fat. I don't have a family history. I exercise all the time. I can't have diabetes. I think I get up 3 times a night because my prostate's too big. She said, Jerry, I've felt your prostate, and it's not that big. You're not getting up 3 times a night because your prostate's big. She leaves the room, comes back with a glucometer, sticks a needle in my finger, and my sugar's 350. Oh, that resident I trained. Damn it, she's good. And damn it, I didn't want to have diabetes. But there it is. And what I found out later, we didn't know this at the time, but what happens with diabetes, most people who come in with diabetes don't present this way. I presented No, I could have presented with nocturia, right? They do present that way. But I was writing it off to something else. I presented with myopathy. I literally had a myopathy. My legs, my muscles worked fine for 20 miles and then went absolutely south. And what happens with diabetes is that, well, what happens with normal physiology is that insulin acts on the muscle cell to let glucose in, it lets potassium in, and it lets phosphorus in. So phosphorus leaves the extracellular fluid space in the blood and gets into the muscle cells to run that ATP glycolytic pathway, right? If you don't make ATP, you don't ride the bike. And if you don't have phosphorus, you don't make ATP. So what was happening is that my muscles were not sensitive to insulin. Phosphorus couldn't get in the cell. So all they would do is the intracellular milieu would store up a little bit of phosphorus. I'd go out and ride my bike and I'd use it all up. And then I couldn't get any more in because I was insensitive. My muscle cells were insensitive to insulin. And so I had a phosphorus myopathy. Thought I had PM. I've never seen any one of these 3 diseases. They may have seen me and I missed them, but I've never made the diagnosis. Okay, so they present with constitutional symptoms: fatigue, weight loss, fever. I had fatigue, but I didn't have weight loss or fever. Now, when they present acutely, they usually have an anti-Jo1 antibody. So these inflammatory muscle diseases, you think of anti-Jo1 antibodies, okay? This is misspelled. Anti-synthetase syndrome is the acute phase, and it's very, very unusual. Anti-Jo1 antibodies associated with one of the two of the following: inflammatory myositis, interstitial lung disease, Raynaud phenomenon, inflammatory arthritis, and mechanic's hands. I'll show you a picture of mechanic's hands in a minute. But mostly what I want you to remember here is that anti-Jo1 antibodies are associated with the acute onset of one of these 3, PM, DM, or okay, let's look at these 3. These are pictures of patients. So there are some cutaneous findings in dermatomyositis. Polymyositis doesn't have these. Dermatomyositis is the one with all the cutaneous findings, okay? And it's Groton papules up on the knuckles of both hands. They're red, inflamed. This is pretty dramatic. This is called heliotrope rash. It's a violaceous erythematous rash. It's on the upper eyelids with hyperkeratosis in people with dermatomyositis. Mostly in sun exposed areas. Here's the shawl sign. This is an erythematous rash over the place where you would wear a shawl. And here's the V sign. So these are sun exposed areas of the skin, patients with dermatomyositis, okay? Remember that polymyositis doesn't get these cutaneous things. And here's mechanic's hands. So these are rough, indurated. I don't think it's very painful. Areas of the radial side of the first and second digits. Most commonly on the first, on the index digit. Mechanic's hands. Okay, diagnosis, clinical history, muscle enzymes, CK, aldolase, and AST. You probably studied the AST when you studied liver disease because we think of SGOT or AST as being a liver enzyme. But what we have to remember is that it's really also a muscle enzyme, and it's really common in muscle. So when you see an elevated AST, when you're looking at your comprehensive metabolic profile, you want to go back and say, well, are there other enzymes that are coming from the liver? You know, is there GGTP? Is there is there alkaline phosphatase? Is total bilirubin normal? If their aldolase, or if their AST is up and all those others are normal, then you need to think about muscle. Okay? CK, aldolase, and AST. Electromyography can be used. You can stick a needle in these inflamed muscles. I don't know how to interpret it, but you send them to an electromyographer or a neurologist, and they'll have a positive electromyography. Autoantibodies, all kinds of antibodies are present in these, but not, you know, only about 30% of the people have these. You don't need to memorize these. You make this diagnosis because of the history. They come in with fever, myalgia, fatigue, painful joints, painful muscles, weakness, and get a muscle biopsy. And what they have are inflamed muscles. Okay. So again, when you're thinking about imaging of the musculoskeletal system, CT for bones, MRI for soft tissue. Okay, that's how you decide whether you want to get an MRI or a CT. I think over your life, who knows what's going to happen over the next 30 years, but while you're practicing, there will be a lot more changes on imaging. It'll change pretty quickly, and it'll be dependent upon technology, but cost of these things will come down. Also, the thing that people are really, really worried about now is getting too many CTs because of radiation. There are really a lot of people worried about cancer in people who are getting too many CTs. So the way these are treated are that you use drugs that are some of the same drugs that we use in rheumatoid arthritis. We use colchicine can actually be used in these inflammatory muscle diseases. It's also the acute gout drug. Hydroxychloroquine, glucocorticoids. Oh no, these are not drugs to treat it. These are drugs that cause it. Colchicine, hydroxychloroquine, glucocorticoids, and statins. So you read a lot about people who are on statins for hyperlipidemia, and I mean, some patients just come in and say, my whole body is just aching. And so it's a controversy in the literature right now as to whether statins actually cause this. It probably does. It's been reported to cause acute muscle disintegration and renal failure, but it's probably not quite as common as we're thinking about. But statins, glucocorticoids, hydroxychloroquine, and colchicine. If you have someone on 30, 40, 50 milligrams of prednisone a day, they'll be weak. It'll make their muscles weak. Your management is high-dose steroids. You use pretty high doses in the acute phase, and then you reduce it to the lowest level they can tolerate. Again, I would use a rheumatologist. You know, this is just too hard to, you don't see it enough, you don't see it very often, so you don't get any experience. You'll more likely screw it up than do it right. So I would at least have a rheumatologist help you. Okay. We're pretty much through with the joint diseases. I'm going to spend some time talking about vasculitides. The vasculitides are now almost always listed in textbooks under rheumatic diseases for reasons that are probably because more and more antibodies are being discovered that cause vascular disease. And so the pathophysiology of the vasculitides is more like the pathophysiology of autoimmune arthritis. So these are a set of illnesses that are inflammation of arteries, veins, or capillaries. And we categorize these vasculitides by big vessels, medium-sized vessels, and small vessels. That's the way I would try to learn them going forward. There are many causes of secondary vasculitis. So when vasculitis is considered as a diagnosis, you've got to look up the causes of secondary vasculitis. There are patients who have vasculitis secondary to something else. Okay, so the large ones, there are two, giant cell arteritis and tracheostomy. So giant cell arteritis used to be called temporal arteritis because that's a common presentation. Common presentation is inflammation of the temporal artery. But we now call it giant cell arteritis, okay? It's the most common primary vasculitis in humans, women greater than men. It occurs in old people. I've never seen this in a young person. I've probably seen 15 patients who are older who come in with this. It characteristically affects the second to fifth branches of the aorta. Now, I don't really have those in my mind. I don't have them counted. Oh, that's the third branch right there. Yeah, that's the fourth branch. But they're big vessels, okay? So what happens here? Well, it's important. Carotids, the temporal arteries, ciliary ophthalmologic arteries, and the temporal arteries are important, especially the arteries of the eye. Okay, those are really important. So what happens here is that dendritic cells in the adventitia of the artery become activated. They become activated by some antigen. Who knows what it is? We don't know. And these dendritic cells then recruit T cells. That happens the same way every time. T cells and monocytes into the vessel wall. The macrophages, which are these monocytes, coalesce to cause giant cells. So if you biopsy them, what you're going to see is these macrophages all collected together in what the pathologist will call a giant cell. And they secrete metalloproteinases, okay? And these metalloproteinases are breaking down the tissues of the vessel wall. And they're obstructing it, and they're making it inflamed, and they're making it hurt. And this inflammatory disease of the vessel can cause ischemia. It can cause closure of the vessel because of all this inflammation inside the vessel. And so the patient might present with scalp pain, headache, tenderness over the temporal artery, jaw claudication. It's an interesting one. Jaw claudication is pretty uncommon. The patient comes in and says, you know, I've got the darndest thing. I can't even chew a bite of my hamburger. I take a bite of my hamburger, and before I can get it chewed up and swallowed, I have to stop because of pain in my jaw. It's literally claudication. Now, the big one is temporary blindness. Amaurosis fugax. If the patient comes in and says, I lost vision in one eye, and then it came back, they literally were blind in that eye. It's almost always because they lost arterial perfusion of the retina, okay? Or if they say I have diplopia, that's usually because one of the cranial nerves lost its bloodstream. Now they have high SED rates. These are, we used to say, if the SED rate's 100 and they've got a headache, they probably have temporal arteritis. You make the diagnosis by doing a temporal artery biopsy. I wouldn't recommend doing that in the office. I'd recommend a surgeon do that. Usually when you cut into an artery, it bleeds and you can't figure out what the hell now to do. I don't know how I'd sew that up and make that better. So I don't ever do that. Now here's the deal. If the patient comes in with temporal arteritis and they don't have visual loss, you can probably get them biopsied, get the diagnosis made, and get them on oral steroids and treat them as an outpatient. If they come in with visual loss, then they have to be hospitalized and get that biopsy done today and get them on IV steroids because they can become blind if this is ignored. They have to be on high-dose IV steroids, high-dose IV corticosteroids. And then they usually respond to this really, really quickly. We used to say that if we made the diagnosis in the outpatient department and they didn't have visual loss, we could give them 100 milligrams of hydrocortisone or prednisone and bring them back, take it as soon as you get home, come back tomorrow morning. And they would come back tomorrow morning and say, man, I've got like $1 million. Headache's gone, I feel great, I've got all kinds of energy. That in itself was thought to be diagnostic. But today, we don't do that anymore. We biopsy them and treat them and then bring that prednisone dose down as quickly as you can to keep them from having symptoms. Polymyalgia rheumatica is a disease that's not really a vasculitis. It's a disease of old people, and they hurt and they're stiff and they have pain and they're fatigued, but we don't have a marker for it. A lot of people think it's on a spectrum, but it's not really a vasculitis that responds to really low dose steroids. You can use 0.5 milligram prednisone sometimes and they get better. Takyasu arteritis is of the aorta and its main branches. It affects young women. I don't know why that is. I don't think anyone knows why that is. It should be suspected in a patient under 40 with symptoms of inflammation, physical findings of vascular disease, decreased pulses, bruits, blood pressure problems. Angiography shows aneurysms and narrowing of the affected arteries. So I think you have to be on your toes. I've never seen this illness, but you have to be on your toes. It's a young person whose physical examination shows that you've got some signs of inflammation in the large arteries. Then you just shoot dye into the affected artery and you see aneurysms and deformities of the arterial wall. High-dose steroids is the treatment. There are 3 medium-sized vascular diseases. Polyarteritis nodosa, primary angiitis of the central nervous system, and Kawasaki disease. I've seen periarteritis nodosa once, and I've never seen the other 2. I don't know if they've seen me or not, but I almost missed polyarteritis nodosa. So here's what happened. This lady comes in, she's about 25 years old. She sees her doctor. I may have presented this case to you before. You may have read this case. Sees her doctor in Ponca City, and the doctor says, you got an infection because you got fever, your CBC, you got a high white count, you got a high SED rate, you got some sort of infection. He starts looking for an infection, he can't find it. So he sends this patient to a good buddy of mine who's an infectious disease doc. And Dan was the best infectious disease doctor I ever saw. He still is. He's at Duke Medical School now, full professor there. But he was here then, and he had her in the hospital for about 10 days, working her up for an infection. He couldn't find it. I was walking down the hall with my residents one day, and he came out of the room. He was sort of wired as if he'd been drinking coffee or something, or taking cocaine, or I don't know what. He said, got this lady in here with an infection, and I don't know what's wrong with it. I can't find it. It's pissing me off. Did you see her? Oh, wait a minute. An infectious disease doc is telling me he's got a patient in here with an infection that he can't find. And he's asking his buddy, a general internist, would you see her? There's only one way Only one way I have a shot at making this diagnosis. He's had her in the hospital for 10 days, and she was in Fungal City in the hospital for a week. What is it? It might not be an infection, but there's only one shot at making the diagnosis. What do I have to do if I have a chance at making this diagnosis? I'm not going to get lucky and it jump out in my head. I have to take a better history than anyone else took. The diagnosis is in the history, especially really hard cases. So I knew this to be the case, and I knew that Dan was a damn good infectious disease doctor. So probably, this patient doesn't have an infection. Probably something else going on here. But I know I need 2 hours. I know I got to sit down and do the most complete history and physical anyone's ever done on anyone. I can't miss anything. And so I did that, and I did a complete review of systems. It was so complete that I went and got the card and asked her every question. And when I got to, do you have any numbness? She said, I got numbness everywhere. I said, what do you mean? She said, I got numbness in my face, it goes away. I got numbness in my leg, it goes away. I've had this for a month, but it doesn't stay more than a few seconds. What is that? We just talked about it a long way. Mononeuritis multiplex. I had read about it, I knew what it was. I'd never seen anyone say they had it. And she didn't tell anyone she had it until I asked her if she had numbness. She's got mononeuritis multiplex. If you type in to Mr. Google, mononeuritis multiplex, I'll bet you a malt or a milkshake or something that the first thing that comes up is polyarteritis nodosa. You can try it tonight. Bet you it's true. It'll be in the first top 3 or 4. She has elevated sed rate. She has fever. She has a high white count. She looks like she has an infection. She feels horrible. And 2 years ago, she had hepatitis B. Okay, so 30. These are medium-sized arteries. Now, here's the other thing. It's that they made a mistake on. She also had hypertension. She also had a metabolic alkalosis, and she had hypokalemia. She's 24 years old. There's a rule. There's a rule. If you're 70 and you have something that looks like an infection and you have something that looks like an endo disease, you might have both because you're old and you've been collecting stuff. But if you're 24, you probably have one disease. And it has to explain, one thing has to explain all this stuff. What do you worry about if someone has hypertension, hypokalemia, and metabolic alkalosis? You worry about renal vascular hypertension. What did the infectious disease doctor do? He called an endocrinologist. The endocrinologist walked in, looked at her lab, probably didn't take a history, probably didn't examine her much. Looked at her lab. She's got metabolic alkalosis, hypertension, and hypokalemia. She's probably got an adrenal disease, so he starts ordering all the adrenal tests. Urine 24-hour urines, every adrenal test known to man. They were all pending when I got there. She doesn't have two different systems. She's got one system. She's got one disease causing disease in several systems. That's what she has. If you have a kidney sitting here, getting blood through the renal artery, and someone comes in and gives you a renal artery stenosis, and you decrease the perfusion of the kidney, what you'll get is a rise in aldosterone. You'll get a rise in renin. You'll get hypokalemia. You'll get metabolic alkalosis. Okay? Renal artery stenosis is one of the causes. That's one on the list. She's got medium-sized arteries coming into her kidney. It's not the renal artery, it's some of these out here. And you do an arteriogram, and she's got polyarteritis nodosa. She's got inflammatory nodules in the medium-sized arteries going to her kidneys. It's an inflammatory disease, but it's not infectious. So the organs involved are kidneys, peripheral nerves, testes, ovaries, GI, coronaries. It can involve virtually any organ in the body because vessels are everywhere. Management is high-dose steroids. DMARDs sometimes are used in this case. This young lady got sent to the NIH. We did an arteriogram, made the diagnosis, sent her to Bethesda to the NIH, and she got on a research protocol and did really well. Primary angiitis of the CNS, I've never seen this disease. Professor Rohr, do you think this is the same illness of the movie Brain on Fire?
I don't know if she had the antibodies were directly on her brain or if they were on the vessels. That was never cleared up at the end.
They called, has anyone seen Brain on Fire? He named the antibodies.
Right.
But I think it's probably somewhat different.
NMDA was the antibody.
Yeah. What is it?
NMDA.
And do you know what that stands for?
No.
NMDA. I think it's a receptor on the brain itself. This is a vasculitis, but
they actually took brain tissue.
yeah, yeah. Well, this one commonly requires a brain biopsy as well. So primary angiitis of the CNS is sort of like the neurologic manifestations of lupus. These people can come in, as the girl did in Brain on Fire. Young, healthy young lady who all of a sudden starts forgetting things, not feeling well, acting out, behaving weird, saying strange things. And so clearly the most likely thing, if you're looking at prevalence, the most likely thing is she's got some sort of psychiatric problem. And the key, it's always there. If you don't want to miss the diagnosis, you got to keep it wide early on. Make sure all the categories are covered. Make sure you think of autoimmune, infectious, congenital, okay, malignant. This is a disease, medium-sized arteries, only affecting the intracranial contents, and you mostly can't make the diagnosis without a biopsy. Biopsy in the brain ain't like biopsying the temporal artery. It's a big deal. So you got to have several people in the room scratching your chins and wondering about this, but you don't want to miss it. High-dose steroids, cyclophosphamide is the treatment. But it's rare. Look at that, 2.4 per million person years. I mean, the likelihood you're going to see this is pretty low. Oh, but an interesting phenomenon. After I saw the lady with polyarteritis nodosa, I worked up about 8 people in the next 2 years for polyarteritis nodosa and never found it. What is that? What is that? It's a bias, right? It's an observation bias. I know that exists, so I'm going to look for it. It's the same mistake the infectious disease doctor was doing when he was looking for infections. You're not finding it. Kawasaki disease. These are usually males. They're generally young. They're of Asian descent. Medium-sized vessels. They present with spiking fevers, conjunctivitis, mucositis of the lips. Mucositis are painful induration and ulcers of the oral cavity. Palmar and plantar erythema, induration, desquamation. What disease would you mistake for this for if you saw it in a 5-year-old? Hand, foot, and mouth disease. Yeah, it looks just like hand, foot, and mouth disease. They've got inflammation of the, they've got ulcers in their mouth, they've got problems on their palms, they've got problems on their plantar fascia. It's treated with IV immune globulin and aspirin. I've never seen it. It must be pretty rare. But once again, if you don't think of it, you won't make the diagnosis. Small vessel disease. There are two categories, ANCA-associated vasculitis and immune complex mediated vasculitis. So I would guess that on PANS, they would like a couple of things. They might like throwing some ANCA at you. And so you've got to know kind of what that is. C-ANCA, P-ANCA, antibodies, and immune complex. They're going to throw something at you about immune complex. Most likely it's going to be that you want to measure C3 and C4 because they're decreased in immune complex disease. C3 and C4 go with immune complex. ANCA. ANCA stands for anti-neutrophil cytoplasmic antibody. So these are antibodies to the neutrophil cytoplasm. And literally, these are antibodies that, here's your poly, that's a multi-load poly, and the antibody comes in and attaches in two places and causes the neutrophil to degranulate. When the neutrophil degranulates, it spills out enzymes, and the enzymes begin to attack stuff. And in this case, the enzymes attack endothelium of blood vessels. These are tiny blood vessels. They can be venules, they can be arterioles, they can be capillaries. And the neutrophils disintegrate. So when you biopsy them, what you find are remnants of neutrophils in the vessel wall. And you see degradation of vessel wall because of these enzymes, and you get disease because these little vessels close up. Okay? So that's ANCA. Sometimes they're C-ANCA, sometimes they're P-ANCA. You don't have to worry about C and P-ANCA, you just have to remember ANCA is a small vessel. Now the three ANCA-associated are granulomatous with polyangiitis. We've talked about this before. We talked about it when we talked about renal disease. This is GMP. It used to be called Wegener's granulomatosis, and it affects the lungs and affects the kidneys. So not only the lungs, but also the upper respiratory tract, sinuses, nose, and upper respiratory tract. So people come in with nosebleed and coughing up blood, and they have a high BU and a creatinine, they probably have Wegener's granulomatosis. Okay? GMP. Microscopic polyangiitis is just small, tiny little vessels. Eosinophilic granulomatosis used to be called Sjogren. This is in people who these are people who all their lives have been atopic. Atopic just means that you are prone to allergies. And then they develop this autoimmune disease, usually affecting the lung, and they have hypereosinophilia. The key to these on screening is you do a CBC with a differential, and they got way too many eosinophils. They commonly present with lung disease, they commonly present with peripheral nerve disease, numbness, mono or multiple neuritis, and they have P-ANCA. Treatment with glucocorticosteroids. Most of these you treat with steroids. Now, immune complex vasculitis are caused by immune complexes. So what happens here is that a dendritic cell stimulates the T cells turn on the B cells, the B cells make antibodies, and antibodies happen to fix complement. And once the complement gets fixed, you have this cascade of inflammatory response in the vessel wall that leads to all the destruction and closure of the small vessels. The key to making the diagnosis is a depressed C3, C4, right? And associated with these are cryoglobulins. Cryoglobulins are antibodies that when you bring them out of the body and send them to the laboratory and you order cryoglobulins, what they do is they take this blood, this serum, and they put it in a refrigerator and bring the temperature down, and at a certain place, these antibodies become active. That's why they're called cryoglobulins. They're antibodies, proteins that become active at a lower temperature. Now, why they become active at body temperature is unclear to me, but nonetheless, that's what happens. Some immune complex vasculitides are due to cryoglobulins. This is just a cartoon that you can look at yourself. It shows the antibody hooking up with the antigen, hooking up with the complement, and attracting neutrophils. The neutrophils get into the vessel wall, and when you biopsy them, you see remnants of the neutrophils. This is called leukocytoclastic vasculitis. This is an immune complex vasculitis. It's the most common on the lower extremities, and it's also called palpable purpura. So when you see purpuric lesions bilaterally on the lower extremities, and you run your hands over them and they're palpable, that's different than blue lesions on the skin that are flat, that you can't feel. Palpable purpura is leukocytoclastic vasculitis until proven otherwise. It's present in all of these small vessels all over the body. Why is it most prevalent in the lower extremities? Because what?
More blood pools there.
More blood pools there, yeah. You got gravity helping you. So when you're standing up, there's a higher pressure inside the venules. And so the stuff has a tendency to leak out more prominently on the lower extremity, causing these palpable purpura. When you biopsy them, you see these leukocytes. You see these leukocytes in biopsy tissue, therefore the term leukocytoclastic vasculitis. Schernlein purpura is seen in children. You'll see this again in pediatrics. It's the most common childhood vasculitis. It presents with abdominal pain and palpable purpura, and it's usually after a viral infection. It usually goes away by itself. Schernlein purpura in children is generally a totally benign disease, unlike leukocytoclastic vasculitis in adults. Scleroderma is an autoimmune disease characterized by fibrosis. So this is an autoimmune disease in which the fibroblasts have gone crazy. And the fibroblasts are laying down collagen and fibrin in various tissues. Sometimes it's localized in a piece of skin, sometimes it's systemic. And when it's systemic, it affects skin, esophagus, vessels. And one of the clinical features of big-time scleroderma is that not only does the person have a difficulty with their facial, they look like they can't smile. Really bad scleroderma patients, they can't smile because they can't. They can't make their face do all the stuff it's supposed to do. So they look like they have no expression. They can't get their mouth very wide open, and they have vascular problems because they have all of this collagen and fibrin in the walls of their small vessels. I had a medical student one time with scleroderma, and her vasculitis, her vascular response to this was so bad that she got claudication trying to write. She could barely get her name written. And so this was back before the electronic medical record, and she had a real problem trying to get stuff down on paper. Okay, so this diagnosis is mostly clinical. Symmetric skin induration of the hands, arms, face, torso. They get digital infarction because of this vesicle disease in their digits. They get interstitial lung disease or dyspnea on exertion. But there is an antibody that's tagged to scleroderma, and you need to remember this, anti-centromere anti-centromere ANA. So this isn't a special antibody, it's just the way the antibody, the general test, comes back. It'll say anti-centromere pattern. And there's not much treatment for this. If they have interstitial lung disease, you might use immunosuppressive drugs, but it's really not a disease that responds to treatment. Sjogren Syndrome, very rare. It's a form of vasculitis infecting small arterial vessels. It presents, well, it's associated with HLA-B51, but Pants isn't going to like this as much as it is ankylosing spondylitis. B51, B27, Vege's disease. These people present with painful ulcers of the mouth. In women, they present with painful ulcers of the mouth and vagina. And it's a difficult diagnosis to make if they don't have those. They have erythematosis, and they have a pathergy test. Have you heard this pathergy test? A pathergy test is that you take a sterile needle, large bore needle, like an 18-gauge needle, and you stick it in the skin. And in normal people, you know, it doesn't cause any major problem except that it hurts. In people with pathergy, they get an immediate inflammatory response around the stick spot. They have erythematosis, which I'll show you in a minute, and pathergy. Sarcoidosis. Sarcoidosis is a disease of unknown etiology, and the term that you'll see on Pants is non-caseating granuloma. Okay? The reason this negative description is used is that when it was described, when it was first found, it was back in the time when tuberculosis was really common. And when tuberculosis, lymph nodes with tuberculosis are cut into and looked at under the microscope, it looks like cheese. And so caseation is a term that sounds like, I guess it describes cheese, maybe in Latin. Is that right? Is that Latin for cheese?
Isn't casein the protein in cheese?
Casein is a protein.
Yes.
And that's the protein in cheese.
Oh.
Is that right?
I think so.
Okay, all right.
Go with it.
Hmm? One of the proteins in dairy. Okay, so it comes from caseation, means looks like cheese. And this is granulomatous tissue that doesn't look like cheese. But people with sarcoid get lymphadenopathy, and they get erythematosis. So if you have somebody who comes in with odd symptoms, you decide, well, I'm going to get a chest x-ray. And what they've got is lymphadenopathy. It's called hilar lymphadenopathy. Bright white lymph nodes sitting on either side of the heart, right in the hilum of the lungs. Big old white spots. And they have erythematosis. They probably got sarcoidosis, and we don't need to do any biopsies. Here's the erythematosis. So these are reddish, bluish lesions that are not toxic. So they're smooth. Erythematosis and palpable purple. The treatment of this disease is symptomatic. You can use aspirin, you can use colchicine, you can use loaded steroids, but I would always have someone help me because the symptoms are really difficult to measure. You can get them on too much steroid. I would just get some help. Wow, it was a marathon. Okay, I think I've emphasized in these 2 lectures on rheumatoid diseases the things you need to be really concentrating on and memorizing for the exam. You'll have an exam on Monday. We've still got 3 or 4 lectures between now and then. If you have questions, don't hesitate to send me an email. I got about 10 papers from yesterday's humanities. So I'd like to have the rest of those back in by sometime this evening, okay? For the rest of you didn't send them. Thanks.
Thank you.
Yep.